With appropriate intervention, the patient with reflex incontinence is expected to achieve continence. Indicators include that the patient often or consistently demonstrates these behaviors, recognizes the urge to void, maintains a predictable pattern of voiding, responds to urge in a timely manner, empties bladder completely, and keeps urine volume in the bladder under 300 mLs. Interventions for the patient with reflex or overflow incontinence caused by obstruction of the bladder outlet may include surgery to relieve these obstructions. The most common procedures are prostate removal and repair of uterine prolapse. Drugs are prescribed for short-term management of urinary retention, often after surgery. They are not used for long-term management of overflow incontinence caused by a hypotonic bladder. Bethanacol, a cholinergic agonist, can be prescribed to help promote bladder emptying. Bladder compression uses techniques that promote bladder emptying and includes the Credé method, the Valsalva maneuver, double voiding, and splinting. For the Credé method, teach the patient how to press over the bladder area, increasing the pressure, or to trigger nerve stimulation by tugging at pubic hair or massaging the genital area. This technique manually helps the bladder empty. In the Valsalva maneuver, breathing techniques increase chest and abdominal pressure. This increased pressure is then directed toward the bladder during exhalation. The Valsalva maneuver is contraindicated in patients who have some cardiac problems because it can trigger a vagal response and cause bradycardia. With the technique of double voiding, the patient empties the bladder and then, within a few minutes, attempts a second bladder emptying. For women who have a large cystocele or prolapse of the bladder into the vagina, a technique called splinting both compresses the bladder and moves it into a better position. The woman inserts her fingers into her vagina and gently lifts the cystocele and begins to urinate. A pessary, which was talked about earlier, can also provide relief from cystocele-related incontinence. Intermittent self-catheterization is often used to help patients with long-term problems of incomplete bladder emptying. It is effective, can be learned fairly easily, and remains the preferred method of bladder emptying in patients who have incontinence as a result of a neurogenic bladder. Important teaching points include proper hand washing and cleaning of the catheter to reduce the risk of infection, a small lumen and good lubrication of the catheter to prevent urethral trauma, and a regular schedule for bladder emptying prevents distension and mucosal trauma. The patient with functional urinary incontinence is expected to remain dry and maintain skin tissue integrity. Indicators include that the patient often or consistently demonstrates these behaviors, uses urinary containment or collection measures to ensure dryness, and manages clothing independently. Causes of functional incontinence vary greatly. Some are reversible and others are not. The focus of intervention is treatment of reversible causes. When incontinence is not reversible, urinary habit training is used to establish a predictable pattern of bladder emptying to prevent incontinence. A final strategy focuses on containment of the urine and protection of the patient's skin. Applied devices include intravaginal pessaries for women and penile clamps for men. The intravaginal pessary supports the uterus and vagina and helps maintain the correct position of the bladder. The penile clamp is applied around the outside of the penis to compress the urethra and prevent urine leakage. Adverse outcomes from pessaries and penile clamps include reduced tissue integrity with tissue damage from pressure and infection from colonization of damaged tissues. Male patients may use an external collecting device such as a condom catheter. Containment is achieved with absorbent pads and briefs designed to collect urine and keep the patient's skin and clothing dry. A major concern with the use of wearable protective pads is the risk for skin breakdown. Avoid using the word diaper when discussing these adult pants because the association of diapers with a baby. More acceptable terms are briefs or pads. Catheterization for control of functional incontinence may be intermittent or involve a long-term catheter. Intermittent catheterization is preferred to long-term catheter because of the reduced risk for infection. Mixed or total urinary incontinence is a combination of two or more types of involuntary urine loss syndromes. For example, stress incontinence and urge incontinence often occur together in women during or after menopause. The problems and interventions for mixed incontinence are the same as for each specific type of incontinence separately.